Have you ever wondered what's in our blood? What it can tell about our well-being? What about the innovative technology used to unravel the mystery of what's in our blood? Hello, I'm Dean Whiting, and this is It's in Our Blood, the podcast series that explores the critical role technology plays in the pathology laboratory, in hospitals, and in the community setting. So I recall on several occasions when I thought I had the flu, I went to the GP and he looked down my throat, listened to my chest, prescribed some antibiotics. I was miserable for a few days, but, within a week or so, I was better. And then one day I did get the flu, and it really knocked me about. I couldn't move for days. It was a horrible experience, and needless to say, I've had my flu shots this winter. But it got me thinking more about the flu. Since it seems to be a very bad flu season this year, I wanted to know more about how we can better handle this epidemic, how technology can help us, and what should individuals do if they get the symptoms. After all, flu can be deadly. To help us today, we're very fortunate to have on the line Professor Bill Rawlinson, Senior Medical Virologist and Director of Serology of the Serology and Virology Lab at New South Wales Health Pathology, Randwick. So welcome, Professor Rawlinson, and many thanks indeed for participating in this podcast.
That's a pleasure.
Excellent. We see in the media quite a lot at the moment that this is a bad flu season. What does that mean for the number of cases of flu we might see this year?
It's always difficult to predict the future, but we regularly see a peak in flu as well as other respiratory viruses around June, July, August, sometimes as late as September. We've seen as many cases so far this year as we saw in the total year for 2018. So we are going to see more cases than last year. That's known. What happens between now and September is really a bit dependent upon vaccination rates, it's a bit dependent upon the weather, and it's a bit dependent upon a number of other factors such as how many people are contacting cases of influenza. It's likely that we'll have more cases than last year because of what we've seen so far, and it's likely it'll peak around July, August, but the total number, it's not clear yet.
Wow. So about 2 years ago, I recall we actually had quite a bad flu season as well. And if I'm correct, we had quite a lot of people pass away or die as a result. From your knowledge, what's the typical death rate and what would you expect from this year?
Death from influenza occurs typically in the older age group or those who are at risk of more severe disease. And each year we see somewhere between about 2,500 and 4,000 Australians die as a result of influenza. So we could expect that again this year. And if it's a worse season, then we may see more death.
Wow. So this makes it, a really serious healthcare condition that we need to be paying a lot of attention to, right?
Yes, and one of the other big things about influenza is that the fact that it's a virus and we have not only vaccines for it, which are safe and effective, but we also have antiviral drugs, which you need to start within 48 hours of getting the flu. Those two things mean that recognising the flu and diagnosing it is extremely important, particularly in a year like this year when we've had more cases.
Yes. And look, is it fair to say that the cause of death in flu, is it mostly the flu virus, or there are other things that people die from, when you have something that looks like or seems like the flu?
So death in influenza can occur exactly as you say, from the flu causing either a pneumonia or much less commonly an encephalitis or an encephalopathy. Wow. So a neurological condition due to influenza, but most deaths in flu are due to a combination of the viral pneumonia and often a supervening bacterial pneumonia with something like pneumococcus, which is a known cause of community-acquired pneumonia. We also see other unusual organisms causing pneumonia like Staphylococcus aureus, and so that bacterial pneumonia is often the cause of final death in these patients. One thing it's important to realise is that although anybody can get the flu, those who die from the flu are typically those in those high-risk groups, which I briefly mentioned before. So the elderly over 65 years of age, Aboriginal Torres Strait Islanders over 50 years of age, pregnant women are at risk because they've not only got a suppressed immune system, particularly in the last trimester of pregnancy, their abdomen just with the baby means that they don't breathe up as much, and so they're also physically at more risk. So pregnant women have two risk factors, which is one of the reasons we are so keen for encouraging them to be vaccinated. People with underlying heart disease, people with chronic lung disease, such as very severe asthma, people with immune suppression, so people who've received an organ transplant, all those groups are really at more risk of dying from influenza, not only, as you say, from the influenza infection, but from the complicating bacterial infections that occur after influenza.
So I mean, am I right in guessing here that it is pretty important to be able to tell the difference between the two, between a viral and a bacterial infection here?
Exactly. So if you're going to treat influenza with very specific drugs, which are called neuraminidase inhibitors, and most people will have heard of Tamiflu, oseltamivir, or Rawlinson, which is an amivir. There are some other drugs now available, very similar actions like peramivir, and there are some others becoming available this year and next. But of course, bacterial infections are treated with a completely different group of antibiotics or antimicrobial antibiotics, and that's very dependent upon what type of bacterial infection. So sometimes, of course, if you have both viral pneumonia due to influenza as well as bacterial pneumonia, say due to pneumococcus, then you'll need treatment for both with an antiviral, say Tamiflu or Rawlinson, and treatment with an antibiotic, say amoxicillin or perhaps another antibiotic, depending upon what you culture.
This podcast is brought to you by Pathology Technology Australia, the peak body representing the companies who invent, manufacture, supply and support the vital technology needed for testing those precious patient samples. Did you know that pathology tests provide vital information for about 70% of medical diagnosis and 100% of cancer diagnosis? Pathology Technology Australia, representing the companies who provide the innovative technology so critical for a high quality, affordable and accessible healthcare system. And you mentioned a moment ago about the importance of having an influenza jab each year. Can you tell me a little bit about, we know the flu virus changes a lot. There are many isoforms of the virus itself. So obviously it's important to have our shots, but tell me how we determine which flu strains are likely to affect us in any one year.
So through the year, our laboratory, as well as others, send our isolates to the WHO collaborating laboratory in Melbourne. That laboratory will grow those isolates, and they'll be used for several things. One of them is to look at vaccine what we call seed strains, so strains for the next year's vaccine, and the other is to actually sequence parts of the genome, and increasingly we sequence the whole genome using whole genome sequencing with newer technology, and that determines the genotypes, which gives you an idea of some of the changes in the virus which will be reflected in the next year's vaccine. And so classification of viruses is based upon typically hemagglutinin and neuraminidase genes, and people will be quite familiar with influenza A, B subtypes, and often we have A subtype H3N2, that is a hemagglutinin subtype type 3, neuraminidase type 2, and this year that's circulating as it has for the last 40 or so years, and it co-circulates with another influenza A strain, H1N1, again, a different hemagglutinin and neuraminidase. And so we use that information to design the next year's vaccine, and there's a meeting between the WHO labs, other experts, and the Therapeutic Goods Administration, the manufacturers, and then at that stage a decision is made based not only on that information, but of course on the information in the preceding winter in the northern hemisphere, because flu typically moves between the northern and southern hemisphere. And what we've got now, the Europe, the US, other northern hemisphere countries will have next winter. That's what we typically see.
And I guess the technology does play an important role here in identifying the actual strain of virus. So that so modern technology, I guess, allows us to do that quickly and efficiently, and to be and for us then to be able to manufacture the correct ratios of vaccine. Is that right?
Indeed, that's correct.
Excellent. So if somebody suspects they have the flu, what should they do?
The first thing is to recognise it and not to spread it. And so simple things like not going to work. If they think they have the flu, they should contact their GP and ask about antivirals. And if they're within 48 hours of having symptoms, then they can have antivirals, and they do reduce the amount of viral shedding. They also reduce the amount of symptoms by a day or so. Thirdly, simple prevention measures: cough into your elbow, not into your hand, cough into a tissue, put it in a bin, wash your hands. Masks are useful sometimes as filters, although of course they can become waterlogged and become less useful. But one of the main things is don't spread it. Don't spread it to people who are at risk. So if you have grandparents or older people in the same house, then avoid contact with them. Very young children, pregnant women, avoid contact with them. And anybody you know who has one of those risk factors that I mentioned, the heart disease, the lung disease, and organ transplant, for that period of time, usually for about 5 to 7 days, when you're most infectious, avoid contact with them. Take it easy. Take Panadol, paracetamol. Don't take aspirin. Aspirin in influenza is associated with a condition called Reye syndrome, which is a reaction to the aspirin, more common in influenza. Bed rest, as I mentioned, antivirals. Contact your GP and, if need be, organise to have antivirals, but organise it in such a way that you don't sit in a GP's waiting room for an hour and cough over the other people.
Yes. So, I mean, I'm aware that there are some flu tests that you can perform, and these can be performed, in the community or near the patient, in hospital emergency rooms. How effective are these in helping manage influenza?
So influenza is important to diagnose. You made the point at the very start about the difference between a cold where you can sort of soldier on and influenza where in the morning you're well and by the afternoon you can't get out of bed. They're very different diseases. And so clinically we do recognise it. However, even in season when there's peak activity, we get it wrong about 2 out of 5 times, maybe 1 out of 5 times. And outside of season, so what we've seen since sort of January of this year, we probably get it wrong about 4 out of 5 times. So when peak season is around, recognition of what we call influenza-like illness clinically is pretty good. However, making a laboratory diagnosis is important. The tests we have available now are often multiplex, so they're often molecular tests based upon PCR, and in a laboratory such as ours, that'll detect up to about 20 or 30 different types of respiratory viruses, including influenza A, B, and it will subtype those as well. In some cases, it will give us information about resistance to antivirals. As you say, there are rapid tests available or near patient tests. They take about half to 1 hour of the actual test. There's a little bit of time either side in terms of resulting. But exactly what you say, it means that people can get a result immediately. New South Wales Health Pathology rolled out last year a series of rapid tests which are performed in laboratories like ours, a reference laboratory, and that allows us to do the test sort of outside of hours or at 2 a.m. in the morning when it may be important to recognise in emergency whether somebody needs to be isolated, treated for influenza or something else. They can also be used in remote sites, and certainly in influenza as well as in other infections, they're starting to be used in remote sites, and they're proving to be almost as accurate, and in some cases as accurate, as the tests that we perform in the laboratory. One of the big downsides so far has been they've only been for flu, so you get a flu yes or no, but you don't get another answer. But even that's improving. There are now multiplexed rapid tests which take, say, 1/2 to 1.5 hours and provide somewhere between 5 and 15 diagnostic answers. So they not only tell you have flu, but if you don't have flu, they'll tell you what you do have. You may have a rhinovirus or an adenovirus or something else. In most cases, that's reassuring because it tells you why you've got symptoms. You're still infectious, but it's not influenza.
Wow. That's incredibly helpful, I'm sure, Professor Rawlinson. So, look, we're out of time now. I just wanted to summarise then what I've learned today, that it's important, if you believe you have the flu symptoms, to manage correctly, to try and avoid the at-risk groups, to cough into your elbow, to isolate yourself somewhat, to get to the doctor and maybe even have a flu test, and if possible get onto the appropriate therapies early. And if not, to get home and take a Panadol and put yourself to bed and just manage your way through it. So it's been very helpful for me. I really appreciate it. Appreciate you joining us today and sharing some of your expertise and knowledge. Thanks very much. Bye for now. Thank you for listening to this edition of It's in Our Blood. Look out for further topics in this series, or go to pathologytechnology.org.au. This podcast is produced by London Agency, Melbourne, Australia.